Good evening, everyone. I hope you are doing well. My name is Dawin SICHIMBA. I'm a medical student at the Copperbelt University School of Medicine in Zambia, and I'm the Director of Operations for the Association of East African Neurosurgeons. So today we are excited to have yet another presentation under the Neuro-Oncology course that has been going on for the past 2 to 3 months. So today this is probably the last case that we're going to have under the Neuro-Oncology course. So before we go into the presentation, I'm going to ask the panelists to introduce themselves, and I'll be calling out the names as they appear on my screen. So I'll call on Dr. Daniel Yamba to introduce himself.
Okay, good afternoon, everyone. My name is Dr. Daniel Yamba from DRC. I'm a general practitioner at Initiative Plus Hospital. So that's it. Thank you.
Thank you, Dr. Daniel. Then we have David Ulrich.
Hello, everyone. My name is David Dari. I am a medical student in Russian, and I am equally the head of communication at the Association of Future African Neurosurgeons, as well as a research fellow. Thank you.
Thank you so much, David. Then we have Hastings Movisa.
Thank you so much, Doc. Good evening, everyone. My name is Hastings Movisa. I'm a medical student from Cavendish University, Zambia.
Thank you, Hastings. Then we have Dr. Yuk.
Yeah, hello, everyone. I'm Dr. Yuk Dokunu from Benin Republic, undergoing neurosurgical training in Morocco, at Rabat in Morocco. Thank you.
Thank you so much, Dr. Yuk. It's really always a pleasure to have you in our midst as one of our seniors here. Then we have Matimba Moli.
Good evening, everyone. My name is Matimba Moli Chilala. I'm a fourth-year medical student at the Copperbelt.
We can't get you, Moli.
Sorry, can you hear me now?
Okay.
Can you hear me?
Yes.
All right. Sorry for that. So my name is Matimba Moli Chilala. I'm a fourth-year medical student at the Copperbelt University in Zambia. Thank you.
Thank you so much. Then we have Dr. Aisha Omar. I hope I've pronounced the name correctly. Okay, we can have Musakanya Shituluka.
Good evening, everyone. My name is Musakanya Shituluka, a final year medical student from the Copperbelt University, Zambia, and I'm glad to be here.
Thank you so much, Musakanya. Then we have Chidiebele. Okay, Olalua Ezekiel.
Good evening, everyone. I'm Olalua Ezekiel, that I'm second-year medical student from the University of Ibadan, Nigeria. Glad to be here. Thank you.
Thank you so much, Ezekiel. Then we have Posta Mtambo.
Good evening, everyone. I'm Tambo Posta, a final year medical student from the Copperbelt University, Zambia.
Thank you so much, Posta. So I think we are going to go straight into the presentation, and I'm privileged to be your presenter for this evening. And like I mentioned earlier, my name is Dawin SICHIMBA, a medical student from Copperbelt University School of Medicine, and equally the Director of Operations at the Association of East African Neurosurgeons. So today we are having case number 10, or rather the case 10 of our neuro-oncology case presentations that we've been having. So I must mention that this is quite an interactive topic, or rather case that we have. So I'm going to ask for your participation as we proceed. So let's look at the case, or rather the clinical presentation that we have in this case. So here we see that a 55-year-old male, a smoker with history of small cell lung cancer, in remission SP chemotherapy and lung radiation, presents with early morning headache and memory problems for the past 3 weeks. And then on the past medical history, it is noted that this patient has this history of small cell lung cancer and hypertension. Then on the social history, this is a non-smoker with history of smoking up to about 30 packs per year. Then a physical exam revealed diminished lung sounds on the right lower lobe. And then there was no focal neurological deficit. Then the first mini mental status exam was a 24 out of 30. So that was the clinical presentation of the patient. And then, so I'm going to ask the panelists what we think the differential diagnosis could be. What would be the differentials? If you receive such a patient, what would come to your mind? What would you think of? What are some of the conditions that you'd think of in such a patient? Should I go back to the history? Let's look at what we have again. So a 55-year-old male smoker with history of small cell lung cancer, inhalation SP chemotherapy and lung radiation, presents with early morning headaches and memory problems for the past 3 weeks. Past medical history, the patient attention, social history, this is a non-smoker who smokes about 30 packs per year. And then physical exam revealed that he had diminished lung sounds on the right lower lobe, no focal neurological deficit, and first in a mini mental status exam was 24 out of 30. So that is the history, and or rather the clinical presentation that we have. So what would we think of? What would we make out of this clinical presentation? So especially to fellow medical students, I would rather we are in the forefront in answering this question. So what would we think of? Please, if you want to say something, if you have an answer, you can just unmute your mic and then you go on and say what you would want to say.
Yes, guys, come on. Anyone should just say something, please.
Yes, so since the patient has a history of small cell lung cancer, we would be thinking of metastasis to the brain.
Okay, so with so Msakanya says, was that Msakanya?
Yes.
It was Molly. Okay, so with this history of small cell lung cancer, Msakanya says we can think of brain metastasis. Any other lines of thought? I don't know. I didn't hear what Dr. Yuk said. Would you please kindly say what you said again, Dr. Yuk?
Yeah, I said, come on, guys, just say something. Say whatever you want, and we will do things together. I was calling up to I was calling up to one of us to participate.
Thank you, Dr. Yuk, for that. So yes, we need to participate. We need to say something. So we are discussing. It's a discussion, and then later on, I'm going to go on and present some literature review about whatever diagnosis we're going to make. Right. So any other lines of thought? Msakanya has mentioned brain metastasis. Any other lines of thought? Since you people don't want to give answers, I'm going to go ahead and present what I've prepared.
No, we can think of, as she said, you can think of brain metastasis. You can think of primary brain cancer. It could be primary brain cancer, like it could be any other tumor of brain cells or brain supporting cells, like, you know. And as what you said, the patient has history of small cells, primary disease, so we could think of metastasis. So so it could also be none of those above. None of those above. It could be patient have complaint of memory loss. So come again, but in the history, they don't talk about if the headache was intense and brutal, or is it progressive. They are talking about, or they are only talking about early morning headache and memory problems. So we could not, we don't have argument to mention something vascular, like vascular malformation, So this cavernoma in the temporal area can give this morning headache with memory problems, you know. But if it was a cavernoma in the temporal lobe, the manifestations can be progressively brutal, progressive. It can be progressive, but not for months and years. No. What else can we think of? Inflammatory, no, we do not have arguments to mention there because they didn't talk about the patients having fever or something. These are the steps of diagnosis that we could think of, you know, metastasis, primary cancer, or vascular malformations, or metabolic problems in the brain. Okay, I think you should go ahead and continue and present your presentation.
Wow. So, like Dr. Yuka has mentioned, so from this history that we have, we can think of a wide range of differentials, right? So you can look at each symptom or each sign that is there and think of whatever can present with that particular symptom. So I've tried to classify the differentials into four. That is number one, we can have neoplasm. Number two, we can have vascular conditions. Number three, we can have infectious diseases. And then we can also have any other that is not either neoplasm, vascular, or infectious disease. So under neoplasms, like Dr. Yip mentioned, we can think of a metastasis from the fact that this is a patient with a history of what? Of small cell lung cancer, like Sakanya mentioned, all right? And then it can also be a primary brain tumor, okay, which can present with any of those signs and symptoms. Then with vascular, we can think of cerebral hemorrhage, and then infectious diseases or other conditions, we can think of cerebral abscess, and then other conditions that we can have is things like progressive multifocal leukoencephalopathy, and then we can also have demyelination, also inflammatory process, or even radiation necrosis, because we can see that this is a patient that has been undergoing radiotherapy, isn't it? So it's possible that they can have this radiation necrosis. Okay, so those are some of the differentials that we can probably think of, and then from there we can go around them and exclude some of them and probably rule in some of them. Of course, how do we come up with a clear diagnosis? We can obviously go for investigations, and obviously the investigations that we need to do, they can either be radiological or laboratory investigations, right? So is there anyone who would want to tell us more about any of these radiological and laboratory investigations? Let's start with the radiological investigations. Which investigations specifically would we do when it comes to radiology?
So
I wish I was teaching. I would have been pointing at it.
Okay, yeah. Can I
Okay,
answer?
yes, Pastor. Yes, sure.
So under radiological, I think we can do a brain CT.
Okay, brain CT.
Then we can also
Right.
do a brain MRI. Then we can also do since we're also dealing with the small cell carcinoma, then we can also do a chest CT and also chest X-ray. So it's good. Yeah.
That's fair enough. That's really good. So we've heard what he has mentioned, right? So brain CT, brain MRI, chest CT, chest MRI, right? So any other lines of thought concerning radiological investigations that we can do?
Yeah, there are some other things that can be done, and also for the brain CT scan and chest X-ray, MRI. Since that the patient is treated for small cells carcinoma, so the MRI should be done first, and this is because we are looking for we've mentioned some differential diagnoses that we are looking for. We are looking for metastasis, or we are looking for primary brain cancer. So when we've done the MRI and we've got an answer, we've got something, we've got a lesion in the brain, then we will come up with this CT scan. Why the CT scan? The CT scan is important for the operating doctor, for the person that want to operate the patient. See if there's no any extension towards the dura mater or the brain or the skull. So first of all, the MRI, and then the CT scan to redirect the operation. And something very important is the PET scan. Over here in Morocco, we are used to we have it in our hospital. We are doing PET scan to all the patients that are diagnosed confirmed metastasis, to find out if there's no other site of diffusion of this tumor. Mostly we found out that because if you don't do this PET scan and you operate the patient, you will have another metastasis less than 3 months. There might be even more aggressive than the first one. So you have to do the PET scan in a third place. The PET scan will come up with the result, and this will redirect also those that we carry on with the chemotherapy and radiotherapy and so on and so forth.
Right. So, Dr. Yu, probably I would, okay, maybe before I direct this question to you, I'll probably try to direct it to the medical students and probably maybe the resident doctors. What would we expect to see on CT scan and MRI? What radiological features would we see and attribute that to the differentials that we've listed? For example, I think we are much entertaining brain metastasis. So what radiological features would we see on brain CT and brain MRI? Anyone, maybe before Dr. Yu helps us with that? Anyone would want to help us with that? Right. Dr. Yu, if possible, you can lead us through that, what we expect to see on brain CT and MRI.
We go on with the MRI first of all. We can expect two things. Either is a primary brain tumor or is a metastasis. The primary brain tumor will infiltrate the brain tissue. You infiltrate the brain tissue and will have a characteristic of intra-axial tumor. Intra-axial tumor, and while the metastasis might not. Metastasis might just having a mass effect on the brain tissue with or without infiltrating the brain tissue. The difference between the metastasis or the primary brain tumor is very tiny. It's not really possible to make this difference with the imaging. It's not, that won't be possible. So anyway, we find a brain lesion, and this brain lesion will present different characteristics, but the characteristics will not for sure allow us to make the difference to know if for sure this is metastasis or this is a brain primary tumor. It won't be possible with either the MRI or the CT scan. That's it will be possible with some other metastasis that will be extraocular, you know. And even if it is extraocular, it might be another tumor like meningioma or something. So what is done to know, if I will answer your question, to know about what we find a lesion, a brain lesion like any other lesion. But if you want to know the nature of the lesion, we will do a biopsy. We go on with the stochastic biopsy of the lesion to send to the pathologist, and they will tell us what it is exactly. About the CT scan, you know, this is tricky. You cannot tell before having the image, like, you know, what you will find. But you know, you might find something, seeing the patient's symptoms and signs and symptoms. You know, you might find something, but you cannot tell. There's nothing specific about this. I don't know if that's what you are asking. There's nothing specific about this small cells lung cancer, different from other tumors. No, there's nothing specific. If it's brain metastasis, you will find a lesion, and then you have to do a brain biopsy to know, because we even have some cases over here with a patient with lung cancer that was undergoing chemotherapy, has done radiotherapy, a series of radiotherapy, and he was undergoing chemotherapy, came up with a brain tumor, and we were like, okay, this should be for sure a metastasis. But I will tell you that this patient, we went to operating theater, we operated him and sent the sample to the pathologist, but it came out not to be a metastasis. You know, yeah, it was a primary brain tumor. It was a pandemoma. So you cannot tell. You cannot tell. If you ask what you expect to find, you expect to find a brain lesion. But which brand of brain lesion, is it metastasis or is it primary brain lesion? You cannot tell until you do biopsy or you operate the patient.
Okay, so let's do this. I've shared that image. So there are 3 images there. So I would want to ask the medical students especially, which imaging modality is A, which imaging modality is B, and which imaging modality is C. And then what is the description of the lesions that are on each of the images? How would we describe that lesion that is being seen? So I would want to first know, or rather get from the medical students, what imaging modalities were used for each of the 3 images there. Anyone would want to tell us the imaging modalities, those?
Okay, I don't understand your question. What do you mean?
The imaging modality.
Describe the image.
Is it, okay, let me give an example. Is it ultrasound? Okay, is it ultrasound? Is it, yeah. Which method, which modality was used? Is it X-ray? Is it what?
A CT scan.
For which one?
A CT scan.
Is it for A? Is it for B? Or is it for C? Or for all of them?
Yeah, for A and B, I think.
Anyone else? Thank you, Mr. Kanya, for that. Nice. Anyone else would want to tell us the imaging modalities? Yes, Poster.
Oh yeah. So the imaging modalities that we're seeing. So A is MRI. B is also MRI. Then C is CT scan.
Right. Okay. In the interest of time, we'll probably proceed. Dr. Yuk, do you want to help us? We'll obviously run to you.
No problem. Yeah, you have to get it. So these are MRI image. These are either A, B, and C. They are all MRI. And the A is MRI is the T1 weighted gadolinium. I mean T1 with injection of contrast. The B is the T1 without injection of contrast, and the C is the T2. So why the C is the T2? Because in T2 weighted brain scan, you have this the cerebrospinal fluid is bright, is a hyper intense. Anything that is fluid is bright, right? And you can see within the jury there are some whitish color you can find over there. This hyper intensity, high intensity colors that you are seeing between the jury are showing the presence of the LCL, the presence of CSF, within the subarachnoid space. So that is what became, and around the lesion that is a frontal, frontal and left frontal lesion. This lesion, you can see that the lesion is in T2. The lesion is heterogeneous. It has high intensity but mixed with low intensity at the middle, which might be a necrosis. They miss this low intensity at the middle. So the lesion is heterogeneous and T2 weighted with a vast edema surrounding it. This around the lesion, you have this continuous high intensity image that is surrounding the lesion. This is the vasogenic edema. The lesion is making mass effect exactly. That's what you're showing. That is the vasogenic edema, because the lesion is making mass effect on the brain cells. These brain cells are swollen in response, getting liquid, getting water inside the intracellular water, and showing that is what is showing in high intensity over there. The B lesion is the T1 without injection of contrast. So it's a T1 weighted lesion, and you can see lesion is in low intensity compared to the brain parenchyma. When we are talking about high intensity or low intensity, we compare the lesion with the brain parenchyma. So it's the brain parenchyma that Dawin is showing right now. And if you compare this brain parenchyma that he's showing, the lesion, you can see that the lesion is more darkened compared to the parenchyma. So this lesion is in low intensity T1 weighted. And in T2, the lesion is enhanced, is highly enhanced, is enhanced in the periphery. In the T1 weighted, the lesion is in the periphery. You can see that the surrounding part of the lesion is in high intensity, whitish. So the lesion is enhanced the periphery, while the middle part remain in low intensity. So in summary, according to the image, this is a frontal, right-sided frontal lesion that is making mass effect on the surrounding tissue with vasogenic edema that is high, that is in high end, highly enhanced with the injection of gadolinium in T1, and in T2 weighted, the lesion is hyperintense. That is how you can summarize it.
Well, thank you so much, Dr. Yuk, for that.
And moreover, you have to add that this lesion with the mass effect, lesion is deviating the middle line. The middle line, exactly. The middle line is deviated around 5 or 7 millimeters. It's very important to mention that. Yeah.
Okay, so I think he has described much of it. Now, what I would want to probably add is that in some literatures, or rather in some settings, there's that sort of conflicting ideas between which one is the first, more like the first line modality to use between. So obviously, like it was mentioned, there's CT scan and there's MRI. CT scan can be contrast enhanced, or it can be non-contrast enhanced. So with contrast enhanced CT, in some settings, they prefer using that to using MRI. So let me just maybe clarify. So image A, this is non-contrast enhanced CT, image B is contrast enhanced CT, and then image C, this is MRI. But I really love the description of the lesions and all the other aspects of it. So that is something that we may take take note of. So sorry about that. Okay, right. So those are the images that we have. So we can see that peripherally, the enhancing right frontal lesion with surrounding T2 bright edema. So like we can see on image C here. So there's that surrounding white, bright edema there, right? So features suggestive of brain metastasis are, number one, localization of the gray-white junction, okay? So we're going to describe, or rather talk about that more under pathophysiology. And then there's also circumscribed margins. So if you look at image A here, especially, I think that's where it's even more clear. You can see that the margins are well circumscribed. Now this is as opposed to primary brain tumors, which tend to be quite infiltrative, like Dr. Yuk mentioned. So metastases are quite circumscribed, and then primary brain tumors, they're quite circumscribed, okay? Then other than that, there's also significant vasogenic edema. So that's the edema, especially if you look at image B, there's this portion here, which is the one that I'm trying to indicate there. And then on image C, I think it's even more clear there. So that is vasogenic edema. Then we also have, sometimes we can also have multiple lesions, right? We can also have multiple lesions that may be present. Okay, so that's about the imaging modality that we can use. So CT scan, CT enhanced, contrast enhanced, and also the corresponding T2 image.
Sorry, Dr. Dawin, can I ask a question?
So sure.
What is the pathophysiology behind primary brain tumors being infiltrative, and then secondary brain tumors being more circumscribed? Okay, so the reason why primary brain tumors are circumscribed, and then the primary brain tumors, they are infiltrative, while the metastases are circumscribed, isn't it? Yes. Okay. So if I'm to answer that, it's basically because, remember, once a tumor is formed, or rather once a tumor starts, it takes a bit of time for it to infiltrate the adjacent tissues, right? So in this case, in the case of these metastases, right, what is happening is that it's coming from somewhere else in the body, and then it lodges, or that it goes in the brain. Now, it hasn't probably taken as much time for it to infiltrate the adjacent tissues. Okay, it hasn't taken so much time for it to infiltrate the adjacent tissues. But when you look at the primary brain tumors, they'll be in the brain for quite some time, and because of that, they're going to be able to infiltrate the adjacent tissues. So I don't know if there could be any other reason why they are usually more circumscribed than, compared to the primary brain tumors. Any addition? Anyone who can add any reason why they are more circumscribed compared to the primary ones?
Yeah. Thank you for your explanation. What we should have in mind is that there is no features, radiological features that can allow us to conclude that this lesion is primary lesion because it's not infiltrating the brain parenchyma And this other one is primary because it's infiltrating brain parenchyma. It could be explained, but we could say, okay, if it's primary brain tumor, primary brain tumor means this is lesions from the brain cells. This is lesion from the brain supporting tissues. I mean the glial tumors and the supporting tissue of the brain cells. So these supporting tissues might be the origin of the tumor. So in this case, okay, it can infiltrate, but radiologically, there's no feature like we could see, because you may have a metastasis lesion, and it will infiltrate quite very well the brain parenchyma. All depend of when the patient comes to me to the hospital. So also the question we should ask is the pathophysiology of all this. A lung small cells lung cancer, how will it get to the brain? Hematogenous metastasis, lymphoid metastasis, lymphatic metastasis. So all this way of metastasis getting into the brain and can disseminate easily. And the third thing to know is the metastatic tumor can be aggressive, even more aggressive than a primary lesion. So far, I don't know, for the best of my knowledge so far, and we don't, if that was possible to make these differences on the image, that would be very nice. So we'll expect from a time from doing biopsy. This is just because we are not sure. I gave just some times ago, I gave an example of patients that may be treated for some other lungs or prostate or liver cancer or something else, and come up with brain lesion, and we are not sure if this is a metastasis or not. It might be, it might not be. So this is why we go doing this stereotactic biopsy. So far till now, we don't have any radiological feature that will allow us to say, yes, if you have this and this is meant for the primary lesion, and if you have this other one and this other one features, this is for metastasis. Thank you.
Right, thank you.
I don't know if I was clear enough to your question.
Yes, you were. Thank you.
Okay, thank you.
Thank you so much, Dr. Yuk. So anyway, that is on radiology. So we have non-contrast and contrast MRI, and then we also have the corresponding T2 image. Then let's look at other investigations that we can do. So we can have a laboratory where we can look at the routine laboratory investigations. Then we can also look at the fecal occult, fecal occult blood test and PSA in men. Now, why are we looking at the fecal occult blood test? It's because, remember, with brain metastasis, one of the common sources of brain metastasis is what? Colorectal cancer, right? So we may probably get something from there. PSA in case of things such as prostate CA. Then imaging, I think we've talked quite enough about imaging, but maybe additionally, the other things that we can do, we can also have chest X-ray, where like in this patient, this is a patient with, maybe before I proceed, Costa, you have a question or you want to say something?
Oh, I just wanted to seek clarity on the radiological images.
Mm-hmm.
Yeah, you said A and B are contrast enhanced CT images, and then on the PowerPoint.
No. Actually, it's
no, they are all MRI.
They are all MRI. Okay.
Oh.
A is non-contrast, then B is contrast enhanced MRI, and then C is a T2 image, also MRI.
I think is the opposite. A is the contrast MRI. B is the non-contrast.
Oh, I'm also confused somehow. What do you mean? I don't know. The labeling of should be image C saying corresponding G2T image. I don't know what that means.
So the G is the end letter of the word corresponding.
And then the T2. I don't know.
The T2 weighted.
Yeah, the T2 image. I don't know what that means, because when I think of T2, for me, I'm thinking of the sacral, sorry, or the thoracic vertebrae, such kind of things. But
no. Yeah, when we are talking about MRI, the MRI is done by sequence. You have different types of MRI. So the times of MRI are called T1, T2. You even have the other one that is called flare, and the other one that there are different types of sequences of the MRI. Okay. So the T1, the MRI is acquisition of the brain. So this acquisition of the brain is done with different times. The first time is the T1, and in T1, the liquid, the liquid is dark in color on the MRI. While in T2, the liquid is whitish, is clear, is whitish in color. So the second difference is that in T1, the white matter is showing dark, while the gray matter is showing a little bit whitish. While in T2, the gray matter is showing gray, which is the gray matter is showing more darkened, and the white matter is showing more light. So there are some features that make us to know that this one is T1, this one is T2, and this other one is T1 with injection of the contrast. About the injection of the contrast, you will see that there are some parts of the brain that are supposed not be enhanced, and you will find them being enhanced on the image, so that we allow you to show that this is T1 with injection. For example, the image A. On the image A, you will find out that at the periphery, you can even see some vessels of the dura mater. You can even see very well the false cerebri at the middle. So all these features are showing that this is after the injection of the contrast. Okay.
Yes.
So this is briefly what we can say about this. The MRI stuff is a broad topic. If you guys want, we can have a course about it. That's no problem. But to answer to your question, this is what I can say about that. Thank you.
Thank you very much.
Right. Thank you so much, Dr. Yuk, for that. Okay, so I was talking about other investigations that we can do. I was talking about chest X-ray. In this case, the patient had small cell carcinoma of the lung, and then we can also do CT, chest, and abdomen, and pelvis, radionuclide, bone scan, full body PET scan, and so on, right? Mammogram, like in females, or rather in women, where we're suspecting breast cancer, because breast cancer is one of the commonest sites where brain metastasis may come from. So other things that we can do, obviously, we can do consultation, we can work with neuro-oncology, medical oncology, radiation oncology, and so on, right? So let's look at briefly the background of brain metastasis. So brain metastasis is any tumor of the brain that originates from a cancer elsewhere in the body, right? And it accounts for, up to about 25 to 50% of all intracranial tumors in hospitalized patients. So it's quite common. In other literatures, actually, it's reported that brain metastasis is up to about half of all brain tumors. Now, when you look at incidence, it's basically estimated to be around 170,000 to 200,000 cases per year. However, it should be noted that this is basically probably an underestimation, because patients usually tend to die from the systemic disease before the symptoms of the metastasis even become visible. So, for example, a patient with lung CA, they're going to die from the lung CA itself before the brain metastasis becomes symptomatic. Okay, and most of the times it is seen that most of these brain metastases are actually detected on postmortem. Now, in terms of mortality, it is reported that these brain metastases cause up to about 100,000 deaths per year. Okay, so what are the main sources? So the main sources of brain metastasis, we have the lungs, breast, melanoma, renal, colorectal, and others. Now, just to mention, we should know that the lungs, compared to breast, lungs are the most frequent source of these metastases compared to breast cancer. However, the reason why lung cancer and breast cancer, they are on top, is basically because they are more frequent, or rather they are more common compared to melanoma. So when you look at the incidence of lung cancer and breast cancer, it's higher than the incidence of melanoma. So this is probably the reason why lung cancer and breast cancer, they are on top of the list, right? But when you look at the propensity or the probability of each of these causing these metastases, we find that melanoma has a higher probability or propensity of causing brain metastasis. So we find that in about 70% of patients with melanoma, there is these metastasis. But in the case of lung cancer, it's only about 30 to 40% of patients with lung cancer, they end up having brain metastasis. And then in breast cancer, only about 20 to 30% of patients end up having brain metastasis, all right? So the only reason why lung CA and breast CA, they are on top is because of their frequency, is because of their higher incidence compared to melanoma. Then there are these terminologies that I would want to mention. Number one, we have what is called solitary brain metastasis. So when we say solitary brain metastasis, we're talking about one brain metastasis with no any other metastatic disease anywhere else in the body, right? So like in the image that I showed, we saw that there was only one lesion there, okay? So assuming there were no any other lesions anywhere else in the body, of course, other than the primary source itself. So in this case, the primary source was the lungs, all right? Now, other than the primary source, if these metastases have not spread anywhere else in the body other than in the brain, and there's only one lesion that is seen in the brain, then we say that that is a solitary brain metastasis. Then a single brain metastasis is where there is one brain metastasis or other lesion, and then there are also significant systemic metastasis. So let's say we have a lesion in the brain, and then maybe we have another lesion maybe in the spine or in another bone or anywhere else in the body, right? So that one, we call it a single brain metastasis. Then we also have what is called oligometastasis. Oligometastasis is where we have a few metastases in two or more organ systems. So you have some in the brain, and then you also have a few others anywhere else in the body. So that is oligometastasis. Then leptomeningeal disease is where you are having these metastases in the what? In the CSF. They are present in the CSF, okay? So that is both for the brain and in the spine. Okay, so those are some of the terms that are quite important to notice, rather to look at when you're talking about brain metastasis. Then what are the symptoms of brain metastasis? Obviously, you're going to have weakness, you're going to have numbness and tingling, you're going to have vision changes, headaches, nausea, vomiting, personality changes, memory loss, and seizures, right? As we saw in our patient, we saw that there was headache, which was described to be early morning headache, and then there was memory loss, Okay, those are some of them that were described in the patient that I presented earlier. So on pathophysiology, we should understand that generally these metastases occur by hematogenous, right? And then the cerebrum is mostly involved. And this is why most of the times when you're talking about brain metastasis, we refer to it as a cerebral metastasis. Now, the reason is because the cerebrum makes up the larger portion of the brain. And other than that, because we're saying that it's, the spread is via the hematogenous spread, right? It means that, and since this cerebrum also takes up much of these blood vessels to the brain, so much of these metastases are going to go to the cerebrum. Hence, the word or the term cerebral metastasis is usually synonymous to a brain metastasis, right? So when you say cerebral metastasis, usually you are probably referring to a brain metastasis and vice versa. Then these lesions are usually also located at the gray-white junction or the watershed areas. Now, the junction between the gray matter and the white matter, like we saw in the image that I showed, that's where usually these lesions are located. And what are called the watershed areas. These are areas where you find that the blood vessels, they become narrow, okay? When the blood vessels become narrow, it means that these metastases, they're going to get trapped in those smaller blood vessels. Hence, they're going to accumulate in those areas. So this is where usually you find that they're going to be located in those areas. Then we also need to understand that they are usually multifocal, particularly when you're talking about lung cancer and melanoma. Okay, and these, they usually cause mass effect and peritumoral edema. So when you look at the image that we had, we saw that there was that peritumoral edema, which was whitish in color, okay? So there's going to be that mass effect, and because of the mass effect, you find that there's also going to be a shift of the line, okay, and also there's going to be the peritoneal edema. Okay, so what are the indications for biopsy? So number one, there's if there's need for diagnosis, and number two, if there's the lesions are not amenable. I think that was the type. If it's not amenable to resection due to eloquent or deep location. So if the lesion is located deep in the brain, you find that it will not be so easy to resect the tumor. So when you talk about treatment, we have medical radiotherapy and also surgical resection. Okay. Now, when we talk about medical treatment, here we can talk about chemotherapy and also palliative care and prophylaxis. Now, specifically with palliation or the palliative care, this is usually done in cases where you want to manage the symptoms and probably, let's say, maybe you want to relieve the pain and so on. Other than that, other than pain management, you also want to give corticosteroids. Remember, there was that peritoneal edema. So you want to reduce the peritoneal edema, so you give corticosteroids. Then other than that, you can also give antiepileptics for prevention or treatment of what? Seizures. So we saw that seizures are some of is one of the presentations or the symptoms of these tumors. Then in terms of prophylaxis, you want to prevent thromboembolic disease. Okay. Then when it comes to radiation therapy, okay, we can have what is called stereotactic radiosurgery. Okay. Now, when we talk of stereotactic radiosurgery, this is where you give up to between 1 to 5 doses of radiotherapy, or rather what are called fractions. Okay. Now, with stereotactic radiotherapy, in this case, you are given more than 5 doses of radiotherapy. Now, this is usually done in cases where the tumor is probably large and you don't want to give the whole dose of radiotherapy at once, because, and also in a case where the tumor is located in sensitive areas where you don't want to damage some of those areas. So if the tumor is large enough and you can't just give the whole dose of this radiotherapy at once. And also in cases where the tumor is located in sensitive areas where you don't want to damage the surrounding areas. So this is why you give more than 5 doses. Maybe you can give about 20 or 30 or whatever dose, or rather whatever number of doses that you'd want to give. Then you also have what is called whole brain radiotherapy. So in the case of whole brain radiotherapy, this is usually given where these tumors multifocal. Okay, so remember we said that they can be, they are usually multifocal. So for example, in a case where you have leptomeningeal disease, where they are surrounded, they are all over in the CSF. So you cannot target any specific area in the brain. So it's like you just want to target the whole brain, wherever those small tumors are. You want the radiotherapy to target those areas. So that is those are the cases where you can do whole brain radiotherapy. Then when it comes to surgical resection, this is where now you're going to do craniotomy and obviously the resection. Now, what we need to know is that many metastases are quite well demarcated within the cerebrum, like I mentioned earlier. This is in contrast to the infiltrative primary brain tumors. Now, the color and texture of the tumor may vary based upon the primary source of that metastasis, but it is usually readily distinguishable from the surrounding brain parenchyma. Just like in the image that we had, it was very easy to distinguish the tumor from the surrounding brain parenchyma. And there's usually also that edema surrounding the tumor. Okay, so that is about the surgical resection and some of the things that we need to know about that. So this is where I end my presentation, unless there are any questions from anyone or any other contributions.
That was okay. You round it up all. So if the patient should be operated and it should undergo surgery, the surgical scheme have to be described. How you need to operate, which approach we can use to take off this tumor and all those things. So I think you've gone through all the necessary things that are remaining. If there's any question, so please ask your question and we will try to answer and carry and go on. Hello guys, do you have any question about the presentation? Okay, Dawin, I think there's no question. Everything is understood.
Okay, so thank you so much everyone for being here, for joining us today in this presentation. This is where we're going to end our presentation for today, and wishing you all a good night.
Thank you.
Thank you.